Okay, so this is EKG number 6 with a rate of 66. And we'll do rhythm next, and let's zoom in real close because this one we got to take a good look at. And you can see here, I think this here is a P, and that is as well, right? And so then these are QRSs. And so we got a P for every QRS and a QRS for every P. And so we got a sinus rhythm, meaning that it's coming from the sinus node. Finally, let's look at our axis. Up and up, normal axis. Let's go back here to do our intervals, actually. And so this would be our PR interval here. And that's actually kind of short, because look, that's what the takeoff is right there. And so that I would probably even say is like 100 maybe, or maybe even 80 milliseconds. So let's say 80 to 100 milliseconds. So that's too small. The PR is the only one that has a lower limit, right? We said 120 to 200. The QRS we said was just going to be less than 120, and the QTC less than 500. And this has a lower limit because when it's too fast, what that means is that things are getting through the AV node or bypassing it somehow. Because right, usually what happens is you get a signal, comes to the AV node, there's a built-in delay here, and that delay is what we see as the PR interval. And so somehow we're getting through it too quickly. That delay is not happening. And there's one way that we know that that happens. It's when there's a extra pathway that signal can come through. And so the signal can kind of zoom through here. It doesn't have to get through the AV node and go through that delay. And so as it goes through that extra pathway, it leaves a little slurring of the QRS, and that's called a delta wave. And if we zoom out, we can actually see that delta wave here. You can see it kind of there, right? So that delta wave is characteristic for WPW, Wolff-Parkinson-White syndrome. And let's come back here and look at the other ones real quickly. The QRS, it's a little bit wide because of that delta wave. So if we were to take it all the way down, it probably would be okay, but looks about right. And then the QT, let's do that one real quick. A line here, a dotted line in the middle, and we're on the okay side. So our intervals look pretty good, except for that PR, which is short, and we know that that is because of WPW. And now let's look at our ST segments and our T waves, okay? And let's start with here. We say, okay, ST segments look good. T waves kind of flat there. I don't see it. T waves actually inverted here. So maybe some T wave flattening and inversion in the lateral leads. Let's go to the other lateral leads. They actually look fine there, and the ST segments look good. Let's go inferiorly. Inferiorly, things look okay. It's a little bit raised here, the ST segment, but it's got a nice concave shape to it. So, take that, with a grain of salt. So it's a little bit elevated with a concave shape. If you're worried about cardiac stuff, maybe that means something. If you're not, maybe it doesn't. Remember, we always interpret tests in light of the clinical picture. And finally, let's look here. ST segments look pretty good. T waves inverted there, biphasic there. So zooming back out again, what do we have here? We have a patient in WPW with a normal rate here, and otherwise some nonspecific T wave changes all over. Now remember the thing we talked about before when we were talking about how do we stop things going through the AV node, and we say it was the drugs A, B, C, D. I'm not going to write it here because I don't want you to associate it with this. A, B, C, D. Those stop this SA node, and what? AV node. And if you stop this, that means all signals are going to go through here. And there is no delay now. There's nothing that could possibly slow it down. And so now you're going to have heart rates that can go 200, 300 beats per minute, which are not compatible with life. And that's why you don't give patients with WPW anything that can slow down the AV node. No adenosine, no beta blockers, no calcium channel blockers, no digoxin. Try procainamide instead. And that is that for EKG number 6. We'll go on to number 7 now, okay? Bye.